Welcome. Welcome to the ERA Journal Club. Each of our ERA seminars takes place on the last Thursday of the month. That's 1700 Central European time, which is 1600 here in Oxford, UK time. Each seminar has picked out a topic from an original research or review article published in NDT or CKJ, and the author or authors will introduce their work. And we'll have at least one expert on the panel. And today it's moderated by myself, Will Herrington. I'm an Oxford-based nephrologist and trialist. And I will help moderate the discussion so it's fairly informal, I hope lively. It certainly is live. And you can type your Q&As, your questions into the Zoom box as we go, and we'll try and answer them. We're trying to keep these seminars down to about 30 to 45 minutes, and it will be recorded and made available on video platforms afterwards for you to listen on the way to work. A special announcement today, though. Today we are joined by Paminda Judge for the first time as a moderator. She's a colleague of mine in Oxford, also a nephrologist and trialist, and she'll be joining the ERA Journal Club formally as a new moderator from September, with two other people who are joining. There's Amaryllis van Kranenburg and Andreas Kronbicher from Germany, and they'll be joining us from September this year. So welcome, Paminda. But today's topic is all about targeting the renin-angiotensin-aldosterone system, the RAAS system, and I mean that RAAS with two A's. It's been a spark of interest with the amazing results from the finerenone trials and the apparently potentially different safety profiles than the ACE inhibitor and angiotensin II receptor blocker trials, which preceded them by some years. And we're very lucky to have both the first and senior authors here for the systematic review that was published in NDT today. And we've got Reid Whitlock, who holds a Master of Science in Community Health Sciences at the University of Manitoba. He's a project manager and senior data decision and support analyst at the Chronic Kidney Disease Innovation Center there, which is led by Dr. Navdeep Tangri, who is the professor of in the division of nephrology at the university. So thank you so much for joining and sharing your paper with the Journal Club.
Happy to be here.
And we're incredibly grateful to Johannes Mann, Hans, who's Professor of Medicine at Friedrich Alexander University of Erlangen. He's the director of the KFH Kidney Center in Munich, and he has been focusing much of his life's work on the physiology of the RAAS system. Starting off in experimental animals, and then more recently, very well known for his role in some of the major clinical trials. So I'm enormously grateful as well for your time, Hans.
I will.
Okay. So we've got a stimulating topic, one which is really directly relevant to clinical care, and we need to take full advantage of the team. So don't be shy, please ask questions as you can in the Q&A box. But for now, Reid, it's over to you. Would you share your screen and perhaps tell us why you were interested in this question, and then start your presentation?
So I guess in conjunction with Nav doing this project, I think one of the reasons I was interested in this is knowing what I know about RAAS inhibitors, that they're used in monotherapy often to help preserve kidney function or lessen the decline, and also help reduce proteinuria. So knowing that there's different RAAS inhibitors out there, just wondering if this is one of the cases where more is better, or does more actually not better, and it might cause some adverse events. So I think knowing that some trials showed that two RAAS inhibitors did have a better effect on reducing proteinuria than one in general, but does that come with adverse events that may not make it worth that benefit?
Yeah, thank you, Reid. And I think from my perspective, this was really a clinically motivated question, because we're now firmly in the era of multi-drug therapy to slow the progression of chronic kidney disease. And with multi-drug therapy, whether it's RAAS and SGLT2 and finerenone, or SGLT2 and finerenone, or RAAS and finerenone, like with any combination of the above, you're always concerned about efficacy and safety. And we know there's some data to come on the combination of SGLT2 inhibitor and nonsteroidal MRA, but we thought that there probably was sufficient data on RAAS and non-steroidal MRA and RAAS and steroidal MRA and dual RAAS, that we could do a reasonable comparison and have a fair degree of clinical certainty about safety. So that was our primary motivation. So maybe I'll start this part of the talk, and then I'll hand off to Reid for methods and results, because that's really sort of, we derived the study question, and then our team, led by Reid, Reid and Sylvia, who's also on the call today, did all the methods and results. So first of all, diabetes is half of chronic kidney disease. It's the most important cause of chronic kidney disease worldwide, and we're really going to pillar-based therapy, right? Almost every patient should have glycemic control, blood pressure control, single-agent RAS blockade, and SGLT2 inhibition. The KDIGO diabetes guidelines, upcoming CKD guidelines all recommend that this is truly first-line therapy for everyone with diabetes. Next slide. So what to do next? Because patients still have residual risk, right? Just because you put people on the first line therapy doesn't mean that your job is done. And therefore, it's plausible that in people with high risk diabetic kidney disease, that additional therapy could get more benefit. Now, previous trials on dual RAAS therapy, which is ACE inhibitor plus ARB, has shown an increased risk of hyperkalemia and AKI, and really no additional benefit on mortality or CKD progression. Next slide. And recently, as we'll alluded to, trials with finerenone, the Fidelio and the Figaro trials were fairly large trials, combined about 13,000 patients, looked at RAS inhibitor plus non-steroidal MRA, and showed that there was a benefit for slowing CKD progression with both agents versus RAS inhibitors alone. However, there was no real comparison between the non-steroidal MRA and a steroidal MRA with RAS inhibitor in people with diabetic kidney disease, and also not a kind of a comprehensive comparison of AKI and hyperkalemia risk with dual RAS blockade. So that was our primary aim, to try and provide users some context on the risks we see with finerenone and RAS inhibitors, and how does that truly compare to, let's say, spironolactone and an ACE inhibitor or ARB, and how does that compare to an ACE inhibitor and an ARB together? Next slide.
Sure. Great. So when setting up this systematic review, as everyone does in the beginning, we set up our PICO question. So our populations were people with diabetic kidney disease. So looking at lab criteria where it was stated, that would be eGFR less than 60 or a urine ACR more than 3 milligrams per gram. But if the lab criteria wasn't explicitly stated, we would also accept those where it was mentioned they had diabetic nephropathy or diabetes with micro or macroalbuminuria or chronic kidney disease. Basically, any indicator that they both had diabetes and chronic kidney disease. We discussed the intervention before, so that was a dual RAS blockade. So a combination of any two of the following drug classes that affect the renin-angiotensin-aldosterone system. So that'd be ACE inhibitors, ARBs, direct renin inhibitors, steroidal or non-steroidal MRAs. And the comparator was just one of those drugs as monotherapy, or monotherapy plus a placebo. And the two outcomes that we were looking at were either hyperkalemia or acute kidney injury. And that was either defined as laboratory criteria or as an adverse event that they would be looking for in patient charts for the clinical trial. So we had two independent reviewers go through the data abstraction, the abstract full text review, and extracting the data. And the senior reviewer was Dr. Sylvia Leon-Mantilla. And we used the Cochrane risk of bias tool for critical appraisal of all the articles that qualified. For the data analysis, we used random effect models, and we compared pooled risk ratios for the differences between rates of hyperkalemia and rates of acute kidney injury between the dual therapy and monotherapy group. We assessed heterogeneity using the I-squared statistic, and we stratified all of our comparisons by different drug classes. So if the dual therapy class had ACE and ARBs, or ACE or ARB and MRA, ACE or ARB and DRI, those were stratified and compared to the same drug class for monotherapy. And we used RevMan 5.4 to do the data analysis, and we used an intention to treat approach wherever possible. So the literature search was starting in 2006 until the end of time when we started the study, which was May 30th, 2022. And the reason we chose 2006 was because there was actually a systematic review on this topic that was published in 2006. So we used that data as a starting point to kind of do adding some new studies to the literature. So in total, we identified 3,482 abstracts after removing duplicates, and 214 qualified for full text review. And we included 31 in total in the systematic review, and 29 in those 30 of those 31 were able to be used for meta-analysis. Overall, 33,048 individuals were included in the meta-analysis. The mean eGFR in all the groups where it was reported was 67.3. So a lot of the trials used stage 1 or 2 CKD with proteinuria. The mean A1C was 7.16. The range was usually from the high 6s until about 8 for mean A1C. So on average, I guess, more mild diabetes. Study size ranged from very small at 26 participants to very large at 8,561. And study duration was also heterogeneous, ranging from 42 days to 5 years, but the most common time point was 1 or 2 years. 15 of the comparisons compared dual therapy of ACE and ARB with an ACE or an ARB as monotherapy. 4 had used DRI plus ACE or ARB as the dual therapy intervention. 6 of them had a non-steroidal MRA plus ACE or ARB, mostly finerenone. And there were 6 studies where the add-on therapy to the ACE or ARB was steroidal MRA, mostly spironolactone, and an additional 2 studies that same dual therapy, but the comparison was actually steroidal MRA as monotherapy rather than an ACE or ARB. In our results, we found that a good plurality of the studies had a low risk of bias in all the domains, mostly the ones that were larger and conducted later. When we did find a higher risk of bias, it was in random sequence generation, allocation, concealment, and blinding, whether it be blinding of participants and personnel or outcome assessments. So there were 21 studies that assessed our primary outcome of acute kidney injury, and 16 of those 21 studies reported at least one event in one of the groups. And there was a total of 1,691 AKIs and 30,925 patients. So in our first comparison, we saw that ACE or ARB dual therapy was associated with a higher risk of AKI compared with ACE or ARB monotherapy. Whereas when we had enough studies for the non-steroidal MRA plus ACE or ARB, we found that when compared to ACE or ARB monotherapy, there was no association with a higher risk of AKI. There was also one study with a low risk of bias that showed no statistically significant association between dual therapy and AKI, and that was when it was spironolactone plus ACE or ARB versus an ACE or ARB alone. And there was also another study with a low risk of bias that showed no risk, and that was with DRI plus ACE or ARB versus ACE or ARB monotherapy. But of course, with only one study in each group, we couldn't do a meta-analysis. For the hyperkalemia results, so for this one, actually all 31 studies that qualified for the systematic review did assess hyperkalemia, and 22 of those studies found at least one event in one of the 2 groups. In total, there were 4,950 hyperkalemia events across 33,048 patients. So the first comparison we show is that ACE/ARB dual therapy was associated with about a twofold higher risk of hyperkalemia compared to ACE/ARB monotherapy. This was the one meta-analysis that did show significant heterogeneity. As you can see, one of the studies shows the point estimate on lower than 1, whereas all the other studies show the point estimate higher than 1. So that was the one study that was driving the heterogeneity. If you remove that study, the meta-analysis, the forest plot, shows about the same risk twofold, and the heterogeneity disappears. For the comparison with non-steroidal MRA plus ACE/ARB, that was also associated with about a twofold higher risk of an AKI, of hyperkalemia. Sorry about the typo on the slide, compared to ACE/ARB monotherapy. When it comes to where steroidal MRA was the add-on therapy to ACE/ARB, we found that the meta-analysis showed a more than 5-fold risk of hyperkalemia versus ACE/ARB monotherapy. And finally, with DRI being the add-on therapy with ACEs or ARBs versus ACE/ARB monotherapy, we saw a 1.35-fold risk in hyperkalemia. And that was, you can see, basically heavily weighted by the Parding 2012 study, which had the vast majority of the events and the vast majority of the patients. So in our systematic review, we had some strengths and limitations. First, this was a comprehensive review, including all possible combinations of dual RAAS inhibition. So that's new compared to when the last study was published in 2006. And this study was also, or this systematic review was also able to add a new class of agents in non-steroidal MRA. So it was the first time that non-steroidal MRAs as add-on therapy to ACE or ARBs was compared to monotherapy in a systematic review. For our limitations, first, different dosing levels were seen in each study, and they were all combined in the meta-analysis. So, and this was because the dose was actually not reported in all studies. Many of the studies just mentioned that it was a maximal dose being used. So it was different dosing levels, and within the drug classes, there were different drugs used. So they all had to be combined in an effort to actually be able to do a meta-analysis. Secondly, as reported earlier, the study durations were also heterogeneous. But in the hyperkalemia and AKI analysis, we found that whenever the timing of the events were reported, they were found earlier in the study, and the increase in creatinine or the increase in hyperkalemia ended up staying consistent throughout the rest of the duration. And then finally, the case definitions of the outcomes were also heterogeneous. In some cases, for hyperkalemia, it was an adverse event that was used. In other cases, for lab-based criteria, it was a cutoff of 5.5 millimoles per liter or a cutoff of 6. Similarly, with acute kidney injury, it was adverse event for about half the studies, and the other half the studies were creatinine-based definitions. So I'll hand it over to Nav to wrap up the presentation here.
Perfect. So thank you, Reid, for that excellent summary of our methods. I think we felt that we could safely conclude that dual RAAS blockade using ACE inhibitors and ARBs is associated with an increased risk of AKI and hyperkalemia compared to RAAS inhibitor monotherapy. This has less clinical implications today because dual RAAS blockade is effectively discouraged by all clinical practice guidelines and is rarely practiced. So now on to the points with larger clinical implications. First, we find that adding a non-steroidal MRA to a RAAS inhibitor is not associated with the risk of AKI. This is confirmed in both the largest randomized trials and in this meta-analysis. The second thing we find is that the increase in risk of hyperkalemia with RAAS inhibitor plus non-steroidal MRA is about twofold It's similar to the dual RAAS blockade, which was previously done, but it's not the same as a steroidal MRA. So, I have very fond memories of the RAAS trial in congestive heart failure, which was published right around the time when I was in medical school. And there was a landmark study in the New England Journal using data from Ontario, Canada, which showed a steep rise in hospitalizations after the publication of RAAS and much broader use of spironolactone. To me, these data suggest that the hyperkalemia signal with finerenone and possibly esaxerenone, so non-steroidal MRAs, is not the same as it is with spironolactone. And those are the important differences in risks and benefits when you're considering dual RAAS combination therapies for the treatment of diabetic kidney disease. So I'll stop there and happy to engage in a discussion with the panel and get questions from attendees. Thank you.
Thank you. Awesome presentation, Reid, Navdeep. Thank you so much for updating the meta-analysis with the really important studies that you've identified. It's what nephrology needs, isn't it? Randomized data, and then someone doing the hard work of putting it all together in some very easy to assimilate forest plots. Thank you. I have a few questions. I'm going to start with a simple one. The categorical outcome of hyperkalemia, you described all the different definitions, but is there a number that you can give us up your sleeve of the type of absolute difference you might expect in potassium when you start an MRA? What's sort of the expected average increase in the studies you saw, and does it vary? Did you see much larger increases in the steroidal MRA trials to correlate with your increase in the higher relative risks? So what's that number we should expect it to increase by?
Yeah, thank you for the question. So in 13 of the studies, they did report a potassium level at baseline and then a potassium level during different points of follow-up. And what we found on average is that when the add-on therapy was an ACE or ARB or a non-steroidal MRA, we saw about a 0.2 millimole per liter increase in potassium, and that was usually very sudden, so within 3 months. And then that difference actually seemed to persist throughout the trials with the longer follow-up. So it was about a 0.2 millimole per liter difference on average, and that was statistically significant. I'll leave it to the nephrologist to decide if that's clinically significant. When the two studies where spironolactone was the add-on therapy, we saw that the increase was between 0.3 to 0.6 millimoles per liter higher, and that was pretty stable as well throughout follow-up.
That's nice, because the absolute differences also seem to correlate with the fact that the relative differences are higher for the steroidal MRAs compared to the other drugs. Okay, so 0.2 is the number to remember clinically if you're using finerenone, by the sounds of it. Hans, do you have any particular questions for Navdeep or Reid?
My first question is about dosing. When I consider the studies that I've seen that used ACEs and ARBs, frequently these studies really used high doses of both. I mean, paradigm study is the on-target study where ramipril at 10 milligrams per day was combined with telmisartan at 80 milligrams per day. So that's the highest doses that you could use in many countries. However, when I look to the MRAs, they have a much wider dosing spectrum. Frequently, let's say spironolactone, and also eplerenone, I use at 12 to max 50 milligrams, and that's how I'm using these drugs. But consider somebody with liver cirrhosis, then it's often used at 100, 200, up to 400 milligrams per day. So there is a much larger dosage spread. Can you take those dosage considerations into your meta-analysis, or
So,
reply whether the differences between the steroidal and non-steroidal MRAs may probably be due to difference in dosing?
Reid, maybe you can comment on the doses seen in the steroidal. I can say on the non-steroidal, certainly with finerenone, there's really only, sorry about that, 10 and 20 milligram doses, which were responsible for a bulk of the data that was in the meta-analysis. Now, when you look at esaxrenone, which is the other non-steroidal MRA, the data came from phase 2, where there were variable doses used, because this was a dose-finding study. So there were 4 different doses, I believe, used in the esaxrenone data, and certainly you do see higher hyperkalemia at the higher doses. So you do see more hyperkalemia. So I think your point is correct. Now, given that esaxrenone is not used from a clinical perspective, I think we're safe to assume that the current doses of finerenone that are out there in the marketplace or are out there on the label reflect a 2-fold or a 0.2. Perhaps if you got to 40 or 80 of finerenone, would you see more hyperkalemia? I suspect you would, but those doses are not around and weren't really tested. Reid, do you want to add about spironolactone doses that were tested in the trials?
Yeah, of the data that was released, most of the spironolactones all the trials were 25 milligrams, and one of them was 25 or 50 milligrams.
So
that's like a RAAS study that you alluded to, and it was similar for eplerenone. I may add to what you were saying, Navdeep, that we know the doses of 10 and 20 milligrams of finerenone, which are, and that's most important, clinically effective. And with that clinical effectiveness, we have so much hyperkalemia. That's the important aspect, that we do not only have the data on the adverse outcome of AKI and kalemia, but also on the clinical events.
Yeah. No, absolutely, absolutely. So you don't need to go higher because you're getting the clinical benefit at that dose. So exactly.
Now, another question for the nephrologist, if I may ask a second question, Will, is the dependence of the findings that you have, or the relationship to estimated or true glomerular filtration rate at baseline. So in other words, the data that you show, do they apply more or less to those with a normal GFR and also to reduced GFR? Could you consider meta-regression analysis, transforming your data according to baseline eGFR?
That's a really good question. I mean, my first thought is that, one, do we have sufficient power? And, at least worth having a look to see how many of the trials were done in people with normal kidney function, normal being eGFR greater than 60 versus less than 60. I think you could suppose that we would all agree that the absolute risk would be higher in people with lower levels of kidney function, right? So the risk of hyperkalemia is directly proportional to eGFR. So if you have a 5-fold relative risk, let's say with spironolactone, that may translate into a very high absolute risk in someone at a GFR of 30 versus 75. Reid, do you want to comment on the average GFR in the trials, if you have that information handy?
Yeah, I think the average was 67. So most of the trials were in earlier stage CKD with proteinuria. There were a handful of trials where the mean eGFR was in the 40s or 50s, so stage 3. And in those ones, some of them, the data is too small because I guess it's harder to recruit patients with lower eGFR. But there's a couple big ones where the Reid study showed a dual therapy had a higher risk of AKI compared to monotherapy, and that was in a trial where the mean eGFR was 44, I believe. And then another study that had a lot of patients had a 1.5 higher risk of hyperkalemia as defined as 6.0, and in that study, the dual therapy and monotherapy group had mean eGFR of 50. So
yeah, that's
it would be interesting to do. So yeah, a better regression would be, I think, very valuable and something that is doable. So, and then we can maybe formalize those numbers more.
Certainly would. I think the individual trials and the Panellist trials have been looking at this, haven't they, in predictors of hyperkalemia. I think low kidney function is one of them. Of course, increased baseline potassium as well. It probably will need individual patient level data to explore it completely, because of course low GFR will be correlated with higher baseline potassium, and meta-regression would be nice to raise hypotheses, but individual patient data would be a real luxury. I wondered if we could go back in history a bit, Nav and Reid. I know it's all ended dual RAAS blockade with RAAS blockade with a single A. But if you look at your figures, it really was the Veteran Affairs Nephron D trial which drove the results for the acute kidney injury figure, and it really is the finerenone 2 large trials which drives the null result for acute kidney injury, where the safety data in your 2 forest plots. The other trials are nice, but they contribute much less, even in the random effect sub-analysis, to the overall effects. Have you thought about whether or not that explanation is really true? I mean, we've assumed it is, and we've confined dual RAAS blockade to what we'd call room 101. But is there an explanation, you think? Could it be the different definitions? Is there a mechanistic explanation? I'm just really curious.
Can we get Johannes to comment? Maybe Johannes, you want to comment on target and what your read was of on target and VA Nephron D? I think what you'd have to say would be more valuable than what we'd have to say on it.
Well, on target was done under the hypothesis, as Reid was pointing out in the beginning, that combining a high dose of an ACE with a very high dose of an ARB would create less cardiovascular and less kidney outcomes. And then it showed that there was no difference in cardiovascular outcomes mortality between the dual therapy and the monotherapy, and there was more kidney outcomes with the dual therapy than with the monotherapy. And that trial was pretty large, so more than 25,000 people followed for close to 5 years. So there was also a power to look at rare events. So 50 patients had acute kidney injury which needed dialysis. And this was in 27 of those with the combined therapy, and only half of those with the monotherapy. There were 2 monotherapy groups, by the way, ramipril and telmisartan, so it was a 3-arm study. And this was really surprising and pretty hard data. And it turned out in the following studies, particularly Amplitude, who didn't believe the data, that this was a finding that could be reproduced, as you said, in Nephron D, and also partly in Amplitude, and both studies were stopped early because of those adverse findings, and also finding no hint of a beneficial effect of the combined therapy compared to monotherapy for either the cardiovascular outcomes, that's Amplitude, or the kidney outcomes, that's Nephron D and Amplitude.
I think it's fascinating, isn't it? Because you're targeting the early part of this RAAS pathway with dual blockers, but a dual approach doesn't seem to be better than just maximal ACE inhibitor or ARB. But it does seem to be that there may be some aldosterone breakthrough or something which is targeted by these non-steroidal MRAs, which do appear to be safer in terms of hyperkalemia risk than the non-steroidal MRAs. It's great to have these randomized data. We've got one question from the audience, which was beginning to use these drugs. It sounds like started finerenone, someone with diabetes and CKD with a potassium in a normal range, and they were admitted with bradycardia and a potassium of 8.3. Is this all the drugs? What do we think?
So I would think there would have to be more than this. Just my own, because I think obviously the average person, as Reid outlined, is going to go up by 0.2, but there's a bell curve, right? But the bell curve I don't think goes that far. So it doesn't take you to 8.3. So I've also been using, finerenone, for example, but I've been initiating in people at 4.8 or less at the beginning, and I'm seeing the same level of hyperkalemia that I'm seeing in clinical trials. So my suspicion would be to get to 8.3, there's something else going on.
Yeah, I would say
Must be.
Must be. Okay,
Will-
good. Don't be put off, is what we're saying, I think.
Yeah.
Don't be put off. There are clear benefits in these trials. You did focus on safety here. It is really worth saying that these drugs were really definitively shown in people with certain types of diabetic kidney disease to slow kidney disease progression, and also had cardiovascular benefits, particularly on risk of hospitalization for heart failure. And we are exploring this more as a community in people with non-diabetic kidney diseases. I'm sure there'll be more trials to come.
Find CKD.
Yeah,
And in type 1 as well, with a new trial recently announced, so which is great.
Will, for you as a moderator, there were also some questions before our meeting that were sent in to ERA. Did you see these?
Yes, did you want to address any of them directly?
Well, the first one was, would you start potassium binders to control hyperkalemia, which is induced by RAAS blockade?
So, I mean, we all practice, so maybe everyone probably has a different approach. So maybe the three of us can say, like, what would you do? I can start. I can say that I have a handful of patients, not more than 2 hands, on chronic potassium binder therapy to enable RAAS inhibitor use. And it's people with a significant amount of albuminuria and or compelling heart failure type indications, where I really think it's important that they stay on treatment. So that's my answer. But answer, Will?
I have less than 1 handful.
I can underline that. But I mean, for one, there is very nice Canadian observational data showing that when hyperkalemia comes up and patients are treated as we are talking about today, then the most frequent reaction of the physicians is to withdraw the drugs completely. So 75% or 74%, based on data of more than or close to 50,000 patients that were followed up, they stop it. What happens in those 74% where it's stopped and in those where it's continued under one or the other additional therapy? Well, those which were withdrawn have a definitely increased risk for cardiovascular and kidney outcomes in the range of a 30% increase in risk. Observational data, obviously, but it speaks to trying the potassium binders, let's say, from my point of view, when nothing else works. So increasing the dose of diuretics or introducing diuretics is number one. Giving bicarbonate, which is not working acutely, which is working on the long term, and things like that. Diet does not play a major role. I think there are not good data that diet is actually working. But that's my take.
No, I think that's very nice.
Potassium binders. And there is a trial running right now that is randomizing patients, once alluded to here, to those taking potassium binder or placebo, and then we see whether the outcomes are less in those taking the binder because they can support longer the RAAS blockers or not.
Thank you, Hans. That's very good advice. I think I agree with you. there's actually a very nice NDT paper I was going to highlight, which is entitled "Steroidal or Non-Steroidal MRAs, Should We Still Enable RAAS using use through potassium binders," which was also published this month in NDT. So there's a real focus on this topic, I think. So if people want to hear opinions of Shankar and Navinathan, then there is a review article on the website. And of course, 2 months ago, we had a whole session from cardiologists in the US describing non-steroidal MRAs and their effects on cardiorenal outcomes and CKD. So hopefully the journal clubs and these papers together will be a resource to help you implement into clinical practice. But I think it's time to ring the bell on our eJournal Club today. So thanks again to Reid, Whitlock and Navdeep Tangri from Canada, Johannes Mann from Germany. Please do just take a couple of minutes at the end of the seminar to fill out our questionnaire. We'd like to get your feedback on the slightly shorter format. And please put a date in your diary. We're going to have a summer break, but we're going to be back in September, the last Thursday of September, when Amaryllis and Andreas will be debuting on the Journal Club, but they brought a fantastic paper, a meta-analysis of phase 3 trials looking at HIF inhibitors, a story which is really very interesting indeed. So come back and see us after the summer, but it's goodbye from the panel, myself and the team at the ERA.